Very pleased to announce to you that today is the first annual pathology diversity grand rounds. It's a mouthful, it's hard to say all at once. Pathology and laboratory medicine diversity grand rounds. And this would be the inaugural session. And we have two guest speakers. We have Dr. Andrea Deyrup from Duke University. And we have Dr. Joseph Graves from North Carolina Agricultural and Technical University joining us today. And I will start with Dr. Graves. He's a professor of biological sciences, and he's a professor at the Department of Biology in North Carolina Agricultural and Technical State University. And he's actually joining us today with his students from evolutionary medicine class. So we also welcome our new guests to today's session. He has multiple books about the importance and effect of race and racism and the theories of race. And many of them are more recently published. One of them is with Ellen Goodman, Race and Racism, Answers to the Frequently Asked Questions. It's a very interesting read. And the others are also available on press if you happen to catch them. He is one of the leads addressing the underrepresented minorities in science, and he aids underserved youth in his region in Greensboro via the YMCA programs. He participates in the task force of Episcopal Diocese of North Carolina for the COVID vaccination. He also serves as the science advisor to the Chicago and New Brunswick theological seminaries through the AAAS Dialogies of Science, Ethics, and Religion, DOSER program. We welcome Dr. Graves, and I'm going to turn it over to Dr. Abbas actually to introduce Dr. Deyrup, because she happens to be the newest addition to the Robbins. Dr. Abbas.
Thank you, Melike. I am really delighted to introduce Andrea Deyrup for this inaugural lecture. Andrea did her MD PhD from the University of Chicago in her residency, and then a fellowship with Sharon Weiss before she accepted a faculty position at Duke, where she started off doing soft tissue surgical pathology, but over the years has more and more developed into their leader in medical education for the pathology course. Duke has a pretty intensive pathology course, and Andrea runs it. And I met her when Vinay Kumar suggested that she could be a valuable contributor to the Robbins books. And in fact, over the last 3 or 4 years, Andrea has been the newest member of the editorial team has truly proven to be a valued contributor. She brings new perspectives, very good common sense, and a closeness to medical students that many of us have lost over the years, or I know some of you haven't, but many of us have lost over the years. So for personal thank you to Andrea for the Robbins books, and I'll turn it over to her for this lecture, which also has become one of her great passions, is trying to understand the importance of racial and cultural backgrounds in both the teaching and the practice of medicine. So Andrea, all yours.
All right, well, thank you so very much, Dr. Abbas and UCSF. It is an incredible pleasure to be here. And Dr. Graves and I are absolutely delighted to be here for this inauguration of your Diversity Grand Rounds. I'd like to begin, first let me close my chat. I'd like to begin by recommending that you go ahead and take a screenshot. This will give you access through the QR code and URL on the left to a box folder that has PDFs of all of the references in this talk, as well as some general references and something I refer to as the Deyrup Disparities document, about which more later. Sorry. Okay, so my first disclosure is that I'm an editor author of 2 of the Robbins Pathology textbooks. We'll be focusing today mostly on Robbins Basic Pathology because that is a book that we are currently revising, and now is the perfect time to look at it with a very close lens. I hope that by the end of this hour, we will have gone through analyzing the concept of race in the context of health and disease, evaluating disparities in the pathophysiology of disease, and describing an approach to improving pathology undergraduate medical education in terms of health disparities. So let's begin with the first one. So at Duke, we have an 11-month preclinical, and I am the course director for Body and Disease, a 5-month course that starts in February. And in February of last year, about 3 weeks into the course, one of my instructors got this email from one of the students wanted to discuss evidence related to racial disparities in blood pressure. So their class received a great deal of conflicting information relating to race and health disparities. And at Duke, we have a 1-year longitudinal course called Cultural Determinants of Health and Health Disparities. And in that class, they were told race is never really a useful proxy or risk factor in healthcare, but other courses had reinforced the use of this category clinically. So the student wanted to discuss why race is so widely used, the evidence behind the practice, and which factors contributed to the disparity. Now, this is something that's been of interest to me for about the last 5 years or so. So I met with my instructor and we talked about it. And I joined his class and told them, my thoughts on the role of race in health disparities. And the students expressed understanding and gratitude, and class continued. Now, I mentioned the date because it was only a couple of weeks later that Ahmaud Arbery was shot to death while jogging in Georgia. And about a month later, Breonna Taylor was shot to death in her apartment. And we all know on Memorial Day, George Floyd was suffocated to death. And this occurred in the background of a pandemic, which we are still undergoing. And I think a time when a lot of us were feeling a lot of existential angst and powerlessness. And these deaths on the background of many others, I think really called on people to look closely and to say, what can I do? It became a time for people to really look at what actions they could do in their particular sphere of influence. And in the context of medical school, medical students began pushing very hard for change. And this was across the country, students who were concerned about health disparities, as well as issues in the curriculum. So when we talk about what can we do, right? So that's what medical students were thinking about in residence. We have what we care about, and then we have our circle of influence, what you can actually do something about. And for me, at this time, it's Robbins Basic Pathology. So I decided that this was the area that I would focus my desire to do something to make a change. To begin with, I went through all of Robbins Basic Pathology using search terms like Asian, African, Hispanic, to find every disease that I could for which we mentioned a disparity. And as you can see, there are a lot of them. This is actually not even a complete list. Let me put this into some context. So here are some of the quotations. The first one refers to cardiac amyloidosis in African Americans. We then talk about carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and EGFR receptor mutations in pulmonary adenocarcinomas of whites and Asians. I would like to take a moment and just say that when these statements were written, they were written with the best of intentions. There is a very strong belief that has gone on for decades in medicine that knowing these epidemiological factors, looking at differences in prognosis, really did relate to race. And it was important for our students to know these things so they would be better physicians. So the intention was very good in writing these. But as we know, particularly when it comes to racism, intention is not the sole metric. Right? We can't just say I had good intentions. We have to look to see, are we causing harm? So I do think that there are several areas in which we can be causing harm by focusing on these disparities. Now, one of them is something I call buzzword bingo. So we take a population of students who are highly motivated to do well on multiple choice questions. And while UCSF has a fantastic open-ended questions and essay questions for your assessment, our students are still taking shelf exams as well as USMLEs. So they're very, very motivated to look at things in a multiple choice question format. And we're teaching them associations. So white, cystic fibrosis, black, sickle cell disease, so that they can quickly go through these multiple choice questions. Now, you may say, well, these are just the preclinical years. And surely they're going to learn the subtle nuances once they're on the wards or when they become residents and young attendings. But I would counter that by saying that there were misconceptions that I learned at the University of Chicago 25 years ago that I did not unlearn until I began doing this disparities work about a year ago. So we make these associations. Is there a possibility that we can create patient harm? So yes, if we teach students that gallstones are associated with American Indians, and a Navajo woman presents with a right upper quadrant pain, an eager attending may think, well, this is probably a gallstone and miss an ectopic pregnancy. Now, you may think that doesn't happen in this day and age. Here is an anecdote from the article, The Misuse of Race in Medical Diagnosis, in which the author talks about a childhood friend who was not diagnosed with cystic fibrosis until she was 8 years old, despite presenting multiple times with classic features of this disease. And she was only diagnosed when a radiologist saw her chest films and could not see the color of her skin and asked, who's the kid with cystic fibrosis, right? So we can harm patients through making associations too closely. But let's take a step further and let's take the lens a little larger. Is there a way that we're creating societal harm? And I think that there is. I think that if we label a certain population as being more prone to disease, as being prone to worse disease, as to having predilections and risk factors that may or may not be choices, that we are reinforcing a position for that population in a social hierarchy. And to me, I think that that can create societal harm. So let's take a look again at this list of disparities. I now will redline for you the diseases that are associated with African descent, as far as having been increased in incidence or having a worse prognosis. And you can see it's well over half of the diseases here. And by comparison, here are the diseases that we associate with patients of European descent, right? So I can imagine a student sitting there and seeing this litany of diseases that are more often associated with Black skin, with African descent, and having emotions and thoughts around that. But I don't need to just imagine. I have a quotation here from Dr. Damon Tweedy's book, Black Man in a White Coat, a doctor's reflection on race and medicine. Dr. Tweedy was a Duke medical student and is now a colleague of mine at Duke on the faculty. And he wrote, "It seemed that no matter the body part or organ system affected, the lecturers would sound a familiar refrain. It's more common in Blacks than in whites. Each time the demographics of a new disease came up in a lecture, my stomach twisted. I knew where this was heading. Seated in a sea of mostly white and Asian faces, I wondered how this information affected their views of Black people, whether they already had biases against us, and whether any of this impacted the way they saw me." So race is an important focus for this talk. And let's take a little moment here and define our terms. Dr. Graves?
Mute myself. Thank you, Dr. Deyrup. So many of you have probably heard this commonly stated platitude: race is not a scientific concept. Now, in actuality, that statement conflates two very different concepts. First, the biological race concept, which has developed across the centuries, beginning with looking at individuals and what they look like, their phenotype or morphology, and then moving on to the geographical location of those individuals. With the coming of the neo-Darwinian synthesis at the beginning of the 20th century, the concept moved into an examination of the frequency of genes between various groups. And later on in the 20th century, phylogenetic techniques were used to determine whether a given species could be shown to have unique evolutionary lineages. Now, I'm going to state to you now, if you've never heard this before, when we use the modern criteria for the determination of whether a given species has biological races, and those are the frequency of genes and whether unique evolutionary lineages can be observed within them, our species, anatomically modern humans, does not have biological races. So I've been misquoted many times, you know, people saying Graves says there's no such thing as race. No, I've never said that. What I've said is that our species doesn't have biological races. Now I want you to contrast that with the socially constructed or socially defined races, which are the subject of what Dr. Deyrup just discussed. In other words, these groupings arbitrarily are created, and they utilize various aspects of morphology, geography, culture, language, and religion. But the difference between the biological race concept and the socially defined or constructed race concept is that the latter only operates in the service of social dominance hierarchy. In other words, this concept was created precisely for the dominance of different human beings in specific social and cultural contexts, not the same as the apportionment of human biological diversity. They're not the same thing at all. Socially constructed defined race may, in some cases, utilize aspects of human biological diversity, but it is not solely prefaced on that. So for example, if you look at Merrill's Introduction to Epidemiology, 7th edition, they make the statement race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Next, please. However, they go on. Racial or ethnic variations in health-related states or events are explained primarily by the exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. And that's pretty much what I argue in this paper, why the non-existence of biological races does not mean the non-existence of racism. And to illustrate the fallacy involved in these socially defined groups, if you take a look at ones commonly used in the US Census, such as white, black, American Indian or Alaska Native, Native Hawaiian or Pacific Islander, I mean, these groups do have some genetically based differences, but certainly not enough to describe them as being legitimate biological races. But also, conflated in these definitions are concepts of ethnicity, which have to do with groups that have a common cultural, historical, social origin. So we also use the term Hispanic origin or not of Hispanic origin. But quite frankly, and we're going to show this in the next couple of slides, when you look at where these groups come from, they come from all across the spectrum of human biological diversity. Next slide, please. So again, if you look at white, a person having origins in any of the original peoples of Europe, the Middle East, or North Africa. Well, the question is, well, how much of this origin? Okay, or black or African American, having a person having origins in any of the black racial groups of Africa. Again, how much? Well, African Americans on average have 16% of their ancestry of European descent. And depending upon which portion of the country, that amount can be dramatically different, such as in Washington State, people defined as African Americans there tend to have upwards of 50% of their genetic origin in Europe, in European ancestry. Again, last but not least, Asian. I mean, really? We're talking about Southeast Asia, Cambodia, China, India, Japan, Korea, and so on. So these folks, again, have different genetic ancestries, and they have dramatically different cultures, but they're all lumped together as if they're the same group. So next slide, please.
All right, so as Dr. Graves was saying, Asia is huge, right? And so it extends here from the Middle East up to Russia, the Far East, down into the Philippines. It includes some of the most populous nations on the planet. So when we see something like the Pfizer COVID vaccine is 74.4% efficacious in Asian Americans, as an Asian American myself, I say, but which ones, right? So let's take another look at Asia in the context of disease. This is looking at hemoglobinopathies. I've outlined the area which is considered Asia. And you can see here, looking at thalassemia, hemoglobin S and hemoglobin C, et cetera, that if you wanted to say something about Asia, you really couldn't say very much. You can't say there is hemoglobin S or there isn't, or there is thalassemia or there isn't, because it's not meaningful for this large group. Now, the reason is, as we all know, is that these various hemoglobinopathies are associated with falciparum malaria. And so the mosquito is not going to respect country borders or continental borders, right? All of the races that we've discussed are really based on continents. And that simply has too much geographic diversity for us to consider that to be sufficient for race. So let's cone down a little bit more on Africa here and talk about the classic African-American disease as we regard it in medical schools, hemoglobin S and hemoglobin C. And you can see here on this map that we have a focus of hemoglobin C in Western Africa. Here in Equatorial Africa, we have hemoglobin S. But even here, we can't simply make a blanket statement that African Americans get sickle cell disease, because you can see that the large areas where on this continent they do not. And it actually varies even within this map. So even though Kenya does have falciparum malaria, if your tribe is high in the mountains, there aren't mosquitoes at those altitudes, and your genetic ancestry is not going to reflect the selection pressure of malaria. So if we look at this map, let's overlay this with a map of where enslaved peoples came from in the United States. And knowing nothing about our country now, you might think that there would be a reasonable incidence of hemoglobin S and hemoglobin C based purely by looking at these maps. And we know, in fact, that that is true. So this is from a screening clinic at Howard University in Washington, D.C. And we see here, as expected, hemoglobin S and hemoglobin C. So you might be thinking, okay, we can't use a continent. We can't use even really a country, right? But if we think really about geographic ancestry and we think about population genetics, perhaps this could be something meaningful that we could use for our students. But you have to think about the fact that a rising share of the US Black population is foreign born. So you can't look at somebody and know where they're from. Furthermore, as Dr. Graves mentioned earlier, the mean amount of European ancestry is about 16% for African Americans. And here we're defining as these people as Americans descended from enslaved persons. Because if you move here from Africa, you are then become technically an African American in the terms of the census, et cetera. But this idea of admixture is very important. And so Dr. Graves is going to take this away now too.
Yeah, so, here we have what are known as ancestry informative markers used by 23andMe in the Burke et al. Study of 2015. Now, the first thing I want to point out for people who aren't familiar with population genetics is the vast majority of these markers come from non-coding portions of the genome. And so therefore they accumulate variants by the force of genetic drift, which is entirely random. And that allows you to find specific loci that might, by blind dumb luck, have large differences between specific portions of the world's geographically separated populations. There's actually a great deal of unifying selection in the exons, in other words, the parts that are coded. So most of what we see in these DNA ancestry tests are looking at segments of the genome that are in fact non-coding and probably have little to no effect on disease predisposition. But having said that, we look at people defined as African Americans across the country, what you will see is that different regions have different percentages of admixture. So again, I mentioned Washington State, but also West Virginia. Whereas when we look in the southeastern United States, we see less European ancestry and more African ancestry. Now, in case anyone is wondering, we know the origin of this admixture in African American populations. And this has been demonstrated by a number of studies showing that this all happened for the most part during chattel slavery. Because after chattel slavery, all of these states enacted laws preventing so-called interracial marriage. And so this occurred during chattel slavery, mainly through the forced rape of women of African descent by their slave masters. These states all came up with laws defining race basically on the race of the mother. And so in that way, none of these children could become socially defined as white because their mothers were enslaved African women. Next slide, please. Now, the situation with persons that we call Hispanic or Latino is more complex because this population represents a three-way admixture between people of European descent, African descent, and Amerindian descent. And again, these percentages can vary widely depending upon which Latinx population you're talking about. Next slide. So if we look in the Caribbean, for example, people from the island of Puerto Rico, again, these are average percentages, are about 16% Amerindian, 72% European, and 12% African in their ancestry. But Mexican Americans, who I would argue are probably the largest population of Latinx descent in California, are only about, are only about 3% of African origin, 51% Amerindian, and about 46% European. So depending upon the country that individuals come from, and in fact within regions within countries, like for example in Colombia, there are two states that are right next to each other, Medellin and Choco, and people from Medellin tend to look like the diagram on the slide. But people from Choco, the state right next to it, are closer to 74 to 84% African ancestry, similar to African Americans. And again, that's because these regions have very different histories relative to the transatlantic slave trade. Next slide.
So I hope that over these last few slides, looking at Asia, Africa, Latinx, that we've brought in this idea that race is not a biologically useful construct. So why are there racial disparities in health and disease? Well, are there disparities in health and disease? Well, of course there are. So here is just a couple of graphs looking at mortality based on cancer. So we have cancer of colon and rectum, uterus and breast, and in all of these, patients of African descent have a higher mortality. But let's not just consider neoplasia. Let's look at some of the more complex diseases like hypertension and diabetes. And this is what is called a heat map. It's almost like what you'd see for your weather map, looking at prevalence of these diseases. So we get an idea of how they're distributed across the country. And as you look at this, you might actually think that whites are in deep trouble because there's a lot of dark red area here, which indicates the higher prevalence. But I would bring your attention to the scale, and you'll see that the worst case scenario for whites for both hypertension and diabetes does not meet the lowest end of the scale for blacks. And if we are to use the same scale, this is what it would look like, right? So clearly there are incredible disparities in health. But once more, there's this question, well, if we don't have biological races, why are there disparities in health and disease? So first, let's just talk about the intersection between genotype and environment. So along the x-axis here are a variety of different genotypes. And then we have along the y-axis on the right, a number of different environments, A, B, C, and D, as well as on the left y-axis, the risk of disease. And you can see that depending on your genotype and whichever environment you're in, you will have different risks of diseases. So what are some of the causes of these disparities? So we've talked a little bit about intrinsic issues. So the idea of a founder effect or bottleneck. So this could be something like what happened to the Ashkenazi Jews during the Holocaust, when their populations were decimated. And they've come back from that, but this was part of what accounts for the high number of recessive diseases. And it's important to recognize that we're talking here about populations, not races. We're not talking about Africans or Asians. We're talking about genetic populations. And then there's the issue of endogamy, which is marrying within one's group. So that can be because of religion, as in the Amish. It could be by caste. And this one, once more, will contribute to loss of heterozygosity and having more similar alleles. And then we have selective advantage, which is we talked about earlier with malaria. There are, however, a whole host of extrinsic causes of disparities, and these are quite frequently linked. So poverty, for example, is going to be related to access to food and living conditions, as well as health insurance and stress. And there are three here on the right I'd like to take a moment to discuss: individual, institutional, and systemic racism. So these terms are now coming into the popular press, although a recent article in Time magazine emphasizes the fact that it is still not in the medical literature. This graphic comes from dismantlingracism.org. For many of us, I think the concept of racism was really tied to personal racism, which is an individual act. The prototypical person in a white coat or white robe, sorry, person in a white robe burning a cross, right? And as we have learned more, we recognize institutional racism, which is how the policies and practices of a group or an institution such as a hospital can have an effect. An example of this would be phenylketonuria testing. When the screening tests were first being developed, they were only done in white children because of the belief that only white children developed PKU. And then cultural and systemic racism are the beliefs, values, and norms of a society. And so, for example, our society does not believe in universal access to healthcare, and that causes health disparities. We also have the process of redlining, which led to extreme poverty and the lack of accumulation of wealth in families of African descent. So let's look at how some of these factors can show up in the literature. So this is a synopsis from Up to Date of these two papers looking at Black, Hispanic, and publicly insured women who needed to get a hysterectomy. And even if they were eligible for a minimally invasive technique like a vaginal hysterectomy or a laparoscopic hysterectomy, they underwent more commonly an open abdominal hysterectomy when compared to white women. As you know, an abdominal hysterectomy is got a higher morbidity, mortality. If we're talking about people who are publicly insured, they probably don't have as long, great, sick days, taking time off to recover from this. And I would say that if you look at the factors, systemic and institutional racism came to play into this regarding health insurance and the hospitals that cared for these women. The ones that had the higher population of Black and Hispanic patients did more abdominal hysterectomies. And then we bring in poverty, education, access to care. And then if we look at something like hypertension and diabetes, I would say that all of these can come into effect, that all of these really have an impact on this population. All right, so we've analyzed the concept of race in the context of health and disease. Let's take a moment and focus on disparities in the pathophysiology of disease, because we're looking at pathophysiology here. So now we're going to go through all of these diseases. Now, actually, I personally am doing that for my students. For each of the diseases for which there is a disparity, I'm doing a deep dive into the literature and providing context. And that is the disparities document that I referenced and have made available to you. For this lecture, however, let's just focus on one disease, cardiac amyloidosis. So the saying in Robbins is that 4% of African Americans carry a specific mutation that increases the risk of cardiac amyloidosis over 4-fold. And there's no additional context provided there. So transthyretin transports thyroxine and retinol in the CSF and blood. It's secreted as a tetramer that can dissociate and form amyloid fibrils in the heart and other tissues such as the nerves. In 1989, a pro-amyloidogenic mutation was identified in a 68-year-old African-American man. And since that time, it's been found that that mutation is about 3 to 4% of African-Americans and about 0.44% of European Americans. So it's autosomal dominant with variable penetrance, which means it can be difficult to pick up. It's more common in men over 60, and it can mimic hypertensive cardiomyopathy, which is relatively common in men over 60. Patients with this diagnosis tend to die 2 to 6 years after diagnosis. Now, based on the allele frequency, it looked like there might be a founder effect here. And the research was done and shows that this allele seems to have originated here in Western Africa and then spread from there. And if we bring back the map of enslaved peoples in our country, you can see why we would have a 3 to 4% incidence here in the United States at this time. And if this were all we had, it would be an interesting story. But there's actually some importance to this because there is a treatment. So there is a drug that can be given to patients with this disease that prevents dissociation and will slow the progression. It does not roll it back, but it does slow it. However, this drug costs about $250,000 a year. So there are additional policy issues in addition to what we're doing just here in pathology. But one of the reasons for this is because it's considered an orphan disease. There are too few patients, so the drug company gets to set their prices. And I would counter that perhaps if we were looking for it, we might find more of it and be able to get patients treatment. And it turns out they do not need to have an invasive cardiac biopsy, which you could see might be something that would be dissuasive. But this can be identified on initial screen with imaging techniques. All right, so now we've looked at these first two objectives, and we've looked at pathophysiology and disease, and we now want to take what we understand about this and improve pathology undergraduate medical education, looking at health disparities. So the first question is race in Robbins data or distraction? And I'm hoping by now at this point in the talk, everyone is saying, well, race isn't relevant because there is no biological race. So how about our focus on disparities? Are disparities in Robbins data or distraction? And I would say, yes. They can be data if we use our understanding of the disparities to identify at-risk populations and to help them get appropriate treatment. And it can be a distraction if we are just lumping groups together as whites with cystic fibrosis or blacks with sickle cell disease. So we want to look at disparities as data. How do we do this? Well, first of all, we have some challenges before we even get started. Are instructors comfortable discussing this material, right? Because, you know, we're pathologists or we're medical instructors, we're clinicians, and we don't receive training in talking about race and racism. So when Dr. Graves and I looked at this text in Robbins, we came up with an additional sentence that would provide context, right? The origin of this allele is in West Africa, in regions that contributed enslaved persons to North America. And what do you do if you have an instructor who says, I don't want to talk about slavery and I don't want to talk about racism. I just want to talk about, you know, transthyretin and amyloidosis. And I would say if you're not comfortable talking about it at this point in American history, you have to become comfortable. Do whatever you have to get the exposure, to get the training, go to workshops, because we are at a crisis in this country. And the way James Baldwin says it is not everything that is faced can be changed, but nothing can be changed until it is faced. And I would say it is our charge to face this. The second issue that comes up is what is important. So we have this enormous weight of what is important for medical students that we have been taught that we teach them, right? And Robbins is actually part of that. I actually think it is such a prominent text that it drives this discussion. So we have an incredible opportunity here, right? So we reflect the USMLE, the USMLE reflects back to us, and we are determining, right, along with the instructors, along with clinicians, what is important. And so when I had talked about this amyloidosis with one of the editors, the comment was, well, this is a rare variant of a rare type of amyloidosis, and probably doesn't warrant a lot of explanation. But my question for that is, okay, we have 2 pages in Robbins on rheumatic heart disease, right? And rheumatic heart disease in the United States has essentially disappeared. There are rare cases, mostly from immigrants. In fact, when I was writing the case for Essential Pathology, my cardiologist said, you can't say it originated in this country. You have to bring in an immigrant because we do not see this, all right? Now, Robbins is an international text, and this is a global issue, right? Rheumatic heart disease in children is significant in lower income countries, no doubt. But I would say, okay, but let's look at everything else. What is important and why is it important? Because we have to decide this. So what do we do next? All right, so we want to fix the issues. We want to look at this. And as a scientist, for me, the most important thing is it must be driven by data. We have to do a thoughtful, mindful analysis of the material. Now, some people might say, well, if there is no biological race, we'll just remove all racial terms. That will take us about 30 minutes going through the Word document, just remove Asian, Latinx, African, and we're done. Now, the problem with that is, first of all, immediately you have people who say, well, that's just politically correct, right? You're just whitewashing things, right? And you get backlash. This is important. These are important data. We have to consider that. And the other thing is that there is some information that is important that we need to glean. We can't just say this is bad and throw it out. Although, as I will discuss later, I think a lot of these data based on race are useless, right? They're based on someone's estimation of the color of someone's skin. It's not looking at genetic admixture, population admixture. It's not done accurately. And so I think not using accurate race compromises a lot of the research we use. We also need to provide context, and we need to be inclusive. And I'll go through how each of these are done. So if we want to do thoughtful, mindful analysis of the material, what's the first step in that? You bring in an expert, right? So I am just delighted as can be that Dr. Graves and I found each other. He has written 3 books on racism and medicine, and nearly 100 articles. He is an evolutionary biologist and brings the right lens to this. So this is not just let's bring in a diversity issue. It's like, let's look at the facts. Let's really think about this in terms of the science. And you need to bring in the medical students, right? Because who are we doing this for? We're doing it for the students, and we're doing it for their future patients, right? And students are much more sensitive and aware of changes in terminology and social changes than the faculty, right? By a long shot. And so I have set up this Google Doc for students to put in anything they find so they can let me know so that I can be aware of this. Now, for a lot of faculty, this is a challenge, right? They're just feeling like, oh, please, I cannot believe they're complaining about this. I'm trying so hard. Or why are they focusing on this? This is so unimportant. But I would say that it's only when there is a push for change, when there is sensitivity, when voices that have not been heard raise up, that change happens, right? Because looking down from where we are, we don't notice things. It's only the people who are pushing up that really help us. And there's an example of that here. This is a young medical student from the United Kingdom who was frustrated because all the images that were being shown in his medical school classes showed lesions on white skin. And he thought, I can't even recognize this on my own skin, right? I don't know what it would look like if I were trying to diagnose it on myself, much less a patient. And so he's written a handbook with some colleagues called Mind the Gap to produce images. Also, this needs to be data-driven, right? So let's focus on keloids for a moment. Keloids, this is the statement, certain individuals seem to be predisposed to keloid formation, particularly those of African descent. So I reached out to the editor. I said, I think we should remove that, particularly those of African descent. And he sent me a quote, a section from Up to Date. And in that section from Up to Date, there was this quotation: keloids have been reported in 5 to 16% of individuals of Hispanic and African ancestry. And for my Disparities document, I have actually read more on keloids than I would wager anyone else in the country at this point. It is a sinkhole one can disappear into. And I had actually read reference number 5 by Chike Obi, in which I found the statistic that dark-skinned individuals form keloids 15 times more frequently than do their lighter-skinned counterparts. Now, that's a very remarkable statistic. And what is also remarkable about the statistic is that I found it in 3 other articles as I was reading. So this led me to look at the initial article where I found this, which was Brissett 2001. And here is the quotation from Brissett. In a review of 175 cases of keloids, Al-Hadi and Sivanatharna found that keloids were 15 times more likely to occur in darker skinned individuals. So I pulled that paper from 1969, and this is what I found, that the relatively fair-skinned Chinese appear to be slightly more prone, and I did the statistics here, to keloids than the dark-skinned Indians and Malays. Now, math is not my strongest suit, but I think that this number is wrong, that is being quoted in literature, not only in 4 papers, but also in up-to-date, right? So this to me, I think, is also just a cautionary tale. When you look at things that refer to race, right, people bring their biases into what they expect to see. So please take everything that you say and look at it more deeply. So how did we end up? So here was our statement. This is the final statement. Keloid formation seems to be an individual predisposition. And we know that it is, right? If I have a first-degree relative who develops keloids, I am prone to develop keloids. But let's take it a step further, right? If a patient comes in and I'm wondering, does that patient have a predisposition to keloids? I don't need to look at the color of that patient's skin. I can look at the patient's skin, right? As an adult, all of us have had some sort of trauma that if we were prone to keloids would form a keloid. So I can look at the patient, I can ask the patient, have you developed a keloid? That tells me what I need to know. I don't even need to think about, geographic ancestry. So we need to provide context. So at the top, I have the sentence from Robbins' 10th edition. We refer to 2 to 15% of whites have factor V Leiden mutation. So first of all, we're talking about something, we're talking about race here. And we don't want to be using terms like whites and blacks, because that means we have to use brown and yellow and red. And I think it's immediately apparent why we don't want to use all of those. And particularly because this one is looking at a genetic issue, we want to refer to ancestry, right? So we want to mention that these are individuals of European ancestry. And yes, we pulled the papers and we looked at them, right? Is it Northern European ancestry? Is it European ancestry, et cetera? And we also want to provide this clue that because of population admixture, it's not just in Europeans, right? And you can't just think, DVT, oh, that person is dark skinned, they don't have factor V Leiden. No, you have to think about it. Okay, and finally, I want to talk about inclusive images, right? So I would like for people to put in the chat what they think the diagnosis is for this skin lesion. And I'm sure that people are scratching their heads on this one. So here is the exact same etiology in a different patient, but also with dark skin, right? It should be apparent to more people now. This was actually, at the time I first started this, was the only published image of this lesion in African-American skin. And this is the one we'll be using in the next edition of Robbins. Okay, if you don't know what this is, here, let's give it away. Here is the exact same lesion in lightly pigmented skin. This is, in fact, the targetoid lesion of erythema migrans, which you see typically in Lyme disease. All right, so you can see why it's much easier to visualize on light skin. So, why is this important? Well, as you know, Lyme disease, if you diagnose it promptly and treat it appropriately, will resolve with minimal sequela. However, if there's a delay in diagnosis, you can then go on to develop neurological symptoms, arthritis, other issues. So one of the things that we know from this paper from Maryland is that of patients who developed Lyme disease associated arthritis, 81% of them said they did not see the rash, right? They had no recollection of a rash at the time that they were finally diagnosed with Lyme disease. And if we look at that patient group, the ones who did see the rash, 70% of them were white, right? And only a quarter of the people who noticed this targetoid rash were Black. And then if you look at who gets Lyme disease associated with arthritis, we can see here that it is predominantly going to be patients with darker skin, right? So this is not a cause and effect, but it is a cautionary tale of how we need to look at things and be aware of what things look like in different populations. So let's go back to our patient. So he presented with this at the emergency department and was told it was cellulitis. Now, he'd gotten a bug bite while he was camping 2 weeks ago with his children and now had chills and fatigue. And I would say that had he been white and had been camping and come in with this particular story, that even with an atypical rash, it would have been, Lyme disease would have been higher on the differential. There are some systemic racism reasons why it is not in African Americans. So he was treated for cellulitis for 10 days, and then 3 weeks later came back to the clinic with this. So he now has a 7th nerve palsy. It was not cellulitis. The diagnosis was made correctly and he was treated, but even 8 months later, he still has fatigue, muscle and lower back pain and cognitive difficulties, and his 7th nerve palsy has only partially improved, right? So what we're talking about here is very serious. It's very important. It has a direct impact on patients and we can make a difference. So I'd like to finish by thanking the Elsevier team and the Robbins editors, Vinay Kumar, Abul Abbas, and John Astor, who have been incredibly supportive of all of this work. And Joe and I would like to thank our colleagues and our students. Now, you can screenshot this and get a list of all of our references, or if you hang on just a moment, you can screenshot this. I've provided, again, the URL and the QR code, as well as a link to dismantlingracism.org. And we would be delighted to take any questions.
People can either ask questions or type them in the chat, and Malika or I will read them out.
I have a question.
Yeah, Aaron, go ahead.
Hi, my name is Aaron Titus. I'm a first-year trainee. I think in some cases, if you replace references to race carefully with references to ancestry, that's good. But I think sometimes it doesn't go far enough. I think you can go further and say that in some cases, people who are essentially using ancestry as a sort of a screening approach, you described race and all the problems with using race in a way that sort of made it sound like race can be sort of a sensitive test, but not a specific test. And in some cases, I think you can go further and make a stronger argument and say that, well, race or a more careful concept of ancestry can be useful, and you still shouldn't use it. Because even though it can be useful because it provides some sensitivity, some sort of screening, it reinforces old stereotypes, delays a reckoning with discrimination and a legacy of discrimination, and that, whenever there's an alternative, we should use the alternative, whether that's genetic testing or anything else. So I think sometimes you can make a stronger argument that that even something that has been useful in the past should not be used at all because it has collateral damage associated with it.
So Aaron, I'm this disparities document that I'm hoping that I'm writing, I'm hoping that in 5 years' time I can just throw it away because this will be gone, right? That we will not be, for me as a clinician, if I look at a patient, my question isn't, what race are you or what is your geographic ancestry? It's what diseases do your brothers and sisters, your cousins, your aunts, your uncles, your parents, your grandparents have? That's going to tell me what I need to know about your genetic background. It's going to give me insight into your environmental background and things that you've experienced. I think that there are some, and there's a lot of resistance to letting go of race as a factor. This whole idea, we do a lot of screening. So for example, EGFR, I didn't include that in this talk, but the whole idea, one of the things we say in Robbins is 10% of whites and 30% of Asians have this. Well, depending on which country in Asia, and depending on the ethnicity of those Asians, it can range from, and depending on your definition of Asia, it can range from 2% to 64%. But does that even matter? Because if a patient comes in with pulmonary adenocarcinoma in the United States, where we have resources, they're going to get mutational analysis done. So how is it useful for medical students to memorize that statistic? So I think you're right that we are moving in that direction.
Yeah, I think just a quick follow-up. I think EGFR is a perfect example where there's pushback and people will say, well, using race as a proxy is still helpful for me. And I think the response has to be that even though you sometimes find it helpful, you still shouldn't use it.
Yeah. And I was going to comment. Well, I was going to comment that.
Oh, sorry, Joe.
Yeah, one of the things I've been trying to do for probably 30 years is get people to realize that even if you were to use Ancestry or any other characteristic to define, a person's origin, as Dr. Deyrup just pointed out, if 70% of a population from country X, carry gene Y, that means that 30% don't. So therefore, knowing that you come from country X is not useful. What you need to know is what are the genetic predispositions that are in your specific family. And that goes across the spectrum of human biological variation. So using these terms in terms of diagnosis, it's a sloppy shortcut that really does need to be eliminated in medical training.
Two more questions, then we'll have to wind up. Catherine?
Hi, thank you. And thank you for the wonderful talk. That was really great. And thank you for sharing the health disparities document as well. I found it really interesting. And I'm in my last year of training and studying for my board exams. And I've just been kind of appalled by how many of these things were expected to memorize for the boards, for example. And I remember a similar phenomenon when I was studying for, the step 1 through 3. And so I was hoping you could reassure us that someone is also working on this in terms of our licensing exams and taking some of this material out. It's a lot of wasted brain space.
So I agree with you completely. I'm going to share a screen for just a month. Well, give me a second to do this. This is, I don't know if you're familiar with, I'll put this in the chat. It's called Crashing Resident. It's a website that goes through how to prepare for the USMLE. And basically one of the comments is be as racist as possible, right? Because, Black people get these 3 things. And, if someone goes to Mexico, actually, I'm not gonna share screen, but if Black people have sarcoidosis, sickle cell disease, keloids, and high blood pressure, Black women definitely have sarcoidosis, right? Asians have a blood disorder called alpha thalassemia. Japanese people have stomach cancer, right? So it's said, it's a satire, it's tongue in cheek, but that was really a part of the boards as recently as 2015. Now the boards are working to remove that, right? So I'm on the APC UMEDS Council, and a number of us are working towards fixing that. However, the retired questions, the shelf exams, all have that. And the other thing to keep in mind is that while educators who are aware are fixing this in the test questions that we have for our medical students, there are a lot of people who aren't aware. And it still is, if the person's Hispanic, they've got diabetes. And if they're Native American, then they've got gallstones. And we need to break that association. But use your voice, right? And we'll be part of the conversation in about 5 minutes to raise that, because you have the power.
Jay and Kelly. Jay, quick questions.
Yeah, thank you for that wonderful talk. I actually was wondering what you think, because I can't help that this is actually adversely affecting pretty much every aspect of peer review. And I know you've focused on education and healthcare delivery, but I mean, at the same time, as a researcher, you're getting all these RFAs that are fundamentally race-based, which, and I'm wondering what your thoughts are, how do you go about essentially eliciting change on that front? I know it's a long process, but what are your thoughts on that?
Andrea, do you mind taking this one?
Step on in, Joe.
Yeah, so one of the things I've been involved in the last year or so is working with editorial boards of leading journals like Nature to change the way they accept the description of human populations and studies. And so this is happening. People are now beginning to rethink what they've allowed, basically what I would call the slop that they've allowed in reporting in journals with regard to the subjects of these studies. I think that will also eventually begin to have an impact on peer review of grants, because if what's appearing in the journals requires a greater degree of sophistication, that's also going to impact the way people act on panels. But you're right, it's going to take some time. And again, it takes individual investigators beginning to speak up about this.
Delia, you had a question, last question.
Yes, thank you. I just want to start. Can you all hear me well?
Yes, we
Okay.
can hear you.
So oh, thank you. So I'm wondering more on the patient side of things as to like how patients of darker skin can understand that they may be prone to or may have caught a wider range of diseases. Because historically speaking, we've been, taught that certain color people are more prone to these diseases. So when something else comes up, like the cystic fibrosis case or the Lyme disease case, and the doctors agree with those historical, diseases, that we could not get those diseases, and so they can't be prevalent in this population or in this patient. What is the patient to do at that point?
So it's very challenging because it requires a patient to be an advocate and to be experienced in literature that we would not expect them. I mean, we can't expect that. When you go to see your physician, the physician is supposed to take care of you, is supposed to understand the breadth of human variation and take care of you. Now, at the same time, there are a lot of heuristics that are being used. The whole idea of think fast and slow, moving quickly now, and the emergency department belief of you got to make your diagnosis in 15 seconds, right? And I think it's part of what is wrong with American medicine, is that we are moving to this algorithm based without taking time. And I don't think we can say, I mean, patients are a very vulnerable population. And I don't think we can put this on them. We can't say, if you have doubts, ask, get a second opinion. I mean, I always tell people to get a second opinion, but really, when you talk about something like this, the people who have the power have to fix it, right? We can ask, patients to advocate for themselves, but since we're the ones who have the power, we have to fix it. It is incumbent upon us to do that.
I think we should close. I thank you again, Andrea and Joel. You're getting tremendous kudos in the chat box. I want to make one personal comment. I think Andrea's involvement in Robbins, the aspect that I have appreciated personally most of all, is that she had made me at least rethink my established biases. There's lots of things that I thought I knew and I thought I had been taught, and most importantly, I thought was scientifically established, and she's pushed us. And at times I've resisted, but I think it's just been a wonderful learning experience. So all of you who are listening, I think that's the way to look at it, is to treat this as a learning experience and re-examine your biases. Thank you, folks. Thank you, Andrea.
Thank you.
Take care. Bye-bye.
Right.